Well, good morning, everybody, and welcome to today's Medical Grand Rounds. Just as a reminder, next week's talk will be in our Value in Healthcare series, and we'll be hearing from Dr. Tim Wilt, who's Professor of Medicine at the Minneapolis VA. He will be discussing improving cancer screening value, defining concepts, and delivering high-value care. Today, we're very fortunate to be joined by Dr. Joshua Freeman, who is Chair of Family Medicine at the University of Kansas Medical Center in Kansas City, Missouri. He's also University of Kansas. In Kansas City, Kansas. Okay. Thank you, Kansas City, Kansas. He is Professor of Preventive Medicine and Public Health, as well as Health Policy and Management. He earned his medical degree at Loyola Stritch, did residency at Cook County Hospital in Chicago, and also later fellowship in faculty development at University of Arizona in Tucson. Dr. Freeman was a Fulbright Scholar in Sao Paulo, Brazil in 2003 and continues to consult there regularly on establishment of family medicine in that country. He holds national leadership roles in family medicine and is co-faculty advisor of the JDOC student-run free clinic at University of Kansas. His research interests have focused in medical education and curricular innovation, as well as healthcare for underserved populations. And we're really delighted to welcome him here today to really discuss the topic of social determinants of health. Thanks, Dr. Freeman.
So thank you very much. It's an interesting that next week you'll be getting a lecture on value. This is, I call a lecture on values, which is sometimes missing from our value-based approach. I thought maybe perhaps it would be, when I first heard about it, based on values, but apparently it's a different set of values. So I thought to start with a little background about social justice and human rights, which is very closely related, what their relationship to health is, and then describe the social determinants of health, how they impact on health and healthcare, how healthcare organizations can be most effective in improving health, and see some examples of how medicine and healthcare have worked to address the social determinants. John Rawls is credited with developing the term social justice, although clearly it's been in use as a concept for centuries. It's now most often cited by religious organizations as part of their mission. And Rawls said in his book, all social primary goods, liberty and opportunity, income and wealth, and the bases of self-respect are to be distributed equally unless an unequal distribution of any or all of these goods is to the advantage of the least favored, and I need to take a breath in the middle of that. But it's an interesting and fairly extreme concept. It says equally distributed, although in the last clause it says unless they're least favored. So if they're least favored, then there are people who are less well equipped, and it's okay to give them more because they need more. But it is only one approach, and I think we can say that even in a society that's very equal, there are going to be some people that, because of physical disabilities or mental handicaps, are going to need more assistance than other people. This is another quote on a similar theme, less extreme. This is actually a photograph taken at the FDR Memorial in Washington, where he said, "The test of our progress is not whether we add more to the abundance of those who have much, it is whether we provide enough for those who have too little." This is less dramatic than Rawls's. He doesn't call for equality. He just says we should be looking at, as a society, helping those who need the help the most. So my question is, do we have a system in the U.S. of social justice as either of these people describe? And I'd say no. In fact, our system is more in which the most privileged exert great influence and mostly seem to use it to increase their privilege. I say mostly seem to because it's not 100% true, and I may be misinterpreting the signs that I see around, but that's what it seems to me to be. Moving on to human rights, this is an interesting document. The UN Universal Declaration of Human Rights was passed in 1948 with no opposition and 6 abstentions. For the record, the U.S. voted for it. Well, there have been a few things which we haven't, but we did. And it has been unmodified since 1948, which is over 60 years, close to 65 years now. No, maybe more, 67 years. And 8? I keep up. My math isn't so good at my age. But it has been unmodified. And the slide is missing, but it basically talks about human rights. And then, so I think I left the slide out, but it's, it talks about the fact that people have the right to dignity, health, a basic level of income, hope for themselves and their families, the sort of thing. It's well crafted, as a lot of these international political things probably took the diplomats a long time, but it's lasted a long time. So I thought that now I'd bring it to medicine and its relationship to medicine. I'm sure you've heard lectures on medical ethics. I would just recap the 4 basic principles of medical ethics. People seem to know what these are. We talk a lot about beneficence. That's a fancy word for do good things for people. And non-maleficence, which means don't do bad things to people. And autonomy, which means people should be able to ultimately make their decisions about their health themselves. And I have classes where I teach medical students, and those two often get into conflict. They go, well, what if somebody really wants something that you think is going to be bad for them? How do we resolve this conflict? But the one we hardly ever talk about is justice. And justice in medical ethics essentially means equity. It means that everybody shouldn't necessarily get the same treatment for the same condition, but they should have the options of receiving the same treatment, so that would be appropriate for their conditions. So in that sense, equity is like it is everywhere else. It's the opportunity for everybody to access appropriate care, and possibly I would extend that to say nobody should have the right to access inappropriate care, or at least harmful care. But it may conflict with autonomy, and part of that depends on how your health system and your society is funded. Is there a sense of social equity where we want to provide a baseline for everyone before anybody gets special stuff, or is it just however much money you have, that's what you could get, even if it's bad for you? Rudolf Virchow, another person I'm going to quote, some of you have heard about. He's a famous doctor, and he had Virchow's autopsy and Virchow's nodes, and he discovered a lot of things which have his eponym on them. But he's most famous as the father of social medicine. In 1848, the Prussian government sent this young doctor to Upper Silesia, a coal mining region of Prussia, to investigate an outbreak of typhus. And he basically came back and said the reason there's an outbreak of typhus is the crummy conditions that the people in the coal miners live in. Cold, damp, polluted with the coal dust, not enough food, not enough shelter. And he came up with this statement. He said, the physicians are the natural advocates of the poor. I've seen that translated as attorneys, but I think that's a mistranslation of advocate. And social problems fall to a large extent within their jurisdiction. This is 1848. Medicine, he said, has imperceptibly led us into the social field and placed us in a position of confronting directly the great problems of our time, even 150 years ago, 160, 70. So we don't see much typhus in the U.S. anymore. But I saw this movie. It's a 1983 movie by Gregory Nava. I think it maybe won the Academy Award for Best Foreign Language Film, Best Doc. And it traces the migration of a brother and sister from Guatemala to Los Angeles. And it's an arduous journey through Mexico, all the way through Mexico. And the last stage of the trip is they crawl through a sewer to get across the border from Mexico into the United States. And I don't want to, spoiler alert, she dies when they finally make it to Los Angeles, and she dies from typhus. And the conclusion is that she acquired typhus crawling through the sewer to get into the United States. And if we say, why did she get typhus, we can say, well, she was infected with rickettsia that causes typhus. because she was bitten by a flea that carries that rickettsia, which lives on rats, which the sewer that she was crawling through was full of. But that really begs the question, why was she crawling through the sewer in the first place? And more profoundly, it raises the question, what is the situation in which somebody finds themselves so that crawling through a sewer full of rats and fleas and rickettsia typhi is better than their alternative? Julian Tudorhart was a Welsh, actually I think he might have originally been English, but he practiced in Wales in another coal mining town in Wales, Glencorrig. Last night somebody came to me and said, I grew up there, he was my family doctor. He was a family doctor in Glencorrig, in a Welsh coal mining town, and he was also a trained epidemiologist, and he did a lot of research on the epidemiology of disease in that town, being the only doctor there. And back in the days when the doctor could say, everybody in town bring me a stool sample, and everybody brought, patient autonomy wasn't quite what it is today. And he published an article in 1971 in The Lancet called The Inverse Care Law. And it was proved with empirical data, this statement that the availability of healthcare services is inversely proportional to the need for it. And I call to your attention that this was, while a long time ago, well after the National Health Service was established in Britain, so at least ostensibly everybody had access to health care and didn't have financial barriers, but still found that out in the Welsh coal mining area, he was the only doctor out there, whereas in more wealthy communities, there might have been more health services. And the implication of this is that more wealthy communities have less need because they are less sick, because their pre-existing condition is less severe. This slide just shows the relative benefit of tertiary prevention. We keep you from having another heart attack after you've had your first one, or maybe secondary, where we look at treating your hypertension to prevent you from having a stroke, or primary, where we give you vaccines and screen. But the social determinants of health is before that because it creates the circumstances in which people's vulnerability to disease is created. Starting in the 1960s, Michael Marmot and colleagues working in Britain did a series of studies collectively called the Whitehall studies, where they wanted to see how is social class related to health. And basically they looked at British civil servants in Whitehall because they said, well, here we're controlling for working conditions. If you look at poor people, they might be in riskier jobs, they might be loggers, they might be ranchers or farmers, they might be in a situation where they're exposed to poisons, so let's look at the people all working in the same offices. And what they discovered was the death rate was directly related to class. The higher you were in the hierarchy, the longer you lived and the less disease you had. And it was a very elegant study that kept going still going on actually. The secondary studies were reported in the 1980s. So I thought maybe a cartoon would be time for a cartoon. I thank Camera Jones, who used to be at the CDC and is currently at Morehouse and is the president of the American Public Health Association this year, for putting together an analogy, the cliff analogy. So everybody could be at risk for health and disease, illustrated here by this cliff you could fall off, right? And you could be in trouble and be hurt. And so could populations of people. They could live on the cliff and be at risk. So what can we do to help them? Well, we can pull up an ambulance. That's tertiary prevention. Once you fall off the cliff and get hurt, we can bring an ambulance and take you to the hospital. But maybe we could do something else. Maybe we could put up a net. So when you fall off, you don't actually hit the ground so hard. And we could think of that as secondary prevention, or safety net hospitals, or safety net clinics. But maybe it would make more sense to put up a fence so people don't fall off. And that would be primary prevention, treating disease early, screening for disease, taking care of it. And all of this here is sort of our medical care system. But another thing we could do is move people further from the edge of the cliff, which makes them less likely to fall. And that would put them in a better position so that they weren't even at risk with a strong gust of wind. And in a sense, we can see this is our medical care system here, and these are the social determinants of health, essentially illustrated by how far do you live from the cliff. How much are you just getting by and not falling off, and a little bit of adversity throws you over the edge. And so the same thing can be true of populations. Populations can live further or closer to the edge of the cliff, and that can be thought of as neighborhoods or areas in which people live, and maybe they live in a neighborhood where the ambulance doesn't come as quickly if they get hurt or sick, or maybe there are no safety net clinics, or maybe there's not even a fence and there's not even any screening programs or primary prevention, and maybe they live right there, so when the wind picks up, they're just getting by, they're just eking out an existence, they're just staying from death's door, and it doesn't take much to push them over the edge. So if we think of this area as being access to health, and maybe it could be addressed by health reform and all the plans that we talk about, whether it's Obamacare, single payer, or anything like that, or value. This is the other stuff, the stuff that puts people in a position where they're likely to get sick, to be injured. And I just listed a few of the things that we consider part of the social determinants of health. Housing, which is arguably becoming one of the most important, because you can't really, we can't really fix very much if you don't have a stable place to live. If you're living on a heating grate, it's hard to clean up your act and get a job. Food, clearly. Warmth. This morning was cold. Education, transportation, the treatment of women, and I emphasize the education of women since internationally that is the single characteristic that is most associated with differential economic advancement, is the level of education of women in a society. The obvious reason is if you don't educate half of the people, you're going to have less economic power. But the other is it's emblematic of how a society is organized. Dr. Jones also has another metaphor, which I won't go through in great depth, but she talks about the social determinants of equity. So you could say, well, all this is related to poverty, and she talks about race as a determinant of health. And isn't it all class, and isn't it all poverty? Poor people do worse, whether they're black or white. And the answer is yes, but the question is, why are there such a high percentage of black people in the lower class? And so that's a question which is one that's a little harder to answer. So what do we have in the U.S. now? We'll talk about health disparities and illustrate some of the disparities that exist. And I point out here that disparities is the official term from the government, but literally it means differences. And it doesn't, we usually mean it to say, and some people are worse off. A term we'll also use is inequities, which is a little bit different because it talks about disparities that are the result of things we could control. So right now, we have disparities based on age. Older people get sicker than younger people. At this point, we haven't figured out how to reverse that. So the disparities that exist on the basis of age are probably going to be more recalcitrant. But disparities based on income or access to healthcare services or insurance could reasonably, or race or whatever, could be called inequities because they could be addressed. Whether we will is another question. I like that this is an article I talk a lot about. It was a Time article by Stephen Brill a couple of years ago, and he talked about, it was a big cover article, and people were shocked that it didn't change the health system, It takes more than just showing facts. I'm not going to change it after this lecture either, But according to one of a series of exhaustive studies, we spend more on healthcare than the next 10 biggest countries combined. And that's dramatic. But usually we look at it more targeted. We say, what do we spend per capita? So our total spending is greater, but how is that affected by the fact that we have a bigger population? Well, China, they have a lot of people. They have more than we do, and yet our budget for healthcare is higher than all these big developed countries. And per capita, we spend, on average, 2 to 3 times what other developed countries spend. The last I saw was about close to $9,000 per person. Norway, which is number 2, spent a little under $6,000 per person, but typically developed countries spend someplace between 3 and 4.5. That's the first world. We could compare ourselves to, the Congo. And we've gotten a lot of technology, a lot of procedures, and a lot of really wealthy corporations and leaders in the insurance, pharmaceutical, device manufacturer, and health delivery fields, but not such great health outcomes. How can I say we don't have great health outcomes? Well, we don't. The United States spends more money on healthcare than any other country, but its health outcomes are worse than other wealthy nations. People in the U.S. experience higher rates of disease and injury and die earlier than people in other high-income countries. And although this health disadvantage has been increasing for decades, its scale is only now becoming more apparent. Some examples. The OECD, I'm sure you know, that's the Organization for Economic Cooperation and Development, so it's another way of describing wealthy countries. Our life expectancy is shorter at birth. Our low birth weight rates are much higher. Our adolescents die at much higher rates from both motor vehicle crashes and homicide, and probably suicide. Adolescents in the U.S. have the highest pregnancy rates and the highest prevalence of sexually transmitted infection, and we have the second highest incidence of HIV and the highest incidence of AIDS among 17 wealthy countries. These are not things to be proud of, I think, in general. Among 29 rich countries, again, this is a UNICEF report from 2013. These are our rankings of 29 countries in a variety of social things: child poverty, the gap between richer and poor children, the measures of childhood safety, infant mortality, low birth weight, and educational well-being. So we're not at the bottom. We're not 29 in any of them. Overall, we're like between Greece and Lithuania, which are not the richest of the rich countries. And this is an illustration of a little bit similar to Marmot's work, which says this is the percentage of people who say that their health is fair or poor, as opposed to good or excellent. And it's linearly related to their education level, which is, of course, usually tied to economic status. But this is education. And, you know, it's like more than a quarter of all people who are less than high school graduates say their health is fair or poor, as opposed to less than 6% of people who were college graduates. I was going to put a slide up here but with the graphs, but just to say, if black people had the same mortality rate as white people, we would have averted almost 700,000 deaths in the 10 years between 1991 and 2000. All medical advances averted less than 200,000 deaths over that time. So it's an indication of the impact of the social determinants of health, and in this case, education, which is obviously associated with economic well-being and access to services. But, you know, white people, white mortality rates are rising too. In a recent big study that came out last year, these economists from Princeton, who were actually looking at something else, discovered this shocking thing, that white mortality rates in the U.S. are going up overall, and at a much steeper rate than minorities. Now, they're still lower than minority mortality rates, but they're growing. And of course, it wasn't surprisingly evenly distributed across class. See a graph that shows it's actually the lower income people who are stable or having increasing mortality rates, not the upper income people. And it turns out that this is not actually new. A study from Virginia Commonwealth showed the same stuff in 2014 and had been looking at 10 or 20 years worth of data. Case in Deaton noted that substance abuse and suicide were the main causes of increased death. I don't know how many of you see that in your practices, that there's more and more people using substances, both illegal and prescribed, opioids as well as alcohol, which is usually legal but not prescribed. And they tie it, as economists, to sort of the loss of the American dream, that the idea that if you work hard, you'll be better off, has been lost for a lot of people. The highly educated professionals, maybe, but for people with lower education and there's less and less hope, and that can lead to suicide. But just note that African American rates are still higher, even though white rates are going up. And this is the graph. This is men, this is women, and these are deciles of income. And as you can see, for men, the death rate, this is not death rate, this is actually survival, life expectancy at age 50. So how much longer you can expect to live if you're 50 for the top deciles of income for men is a long time, and it's grown over the last 50 years. Actually, this is 1920, so 90 years. But for the poorest decile, it's been pretty flat. And you can still expect to live about the same amount more at the age of 50 if you're poor as you could have in 1920. For women, it's even more dramatic. Women tend to live longer, so they can expect to live longer when they're 50. But if you look here, for the bottom 3 deciles, the rate is actually going down. So in the bottom 3 deciles of income, women who are 50 years old will live more years than they would have in 1920. And that's pretty shocking considering the advances we've made in medical care and everything else, and that has nothing to do with medical care, it has to do with the social determinants of health. This just came out in December. I just thought I'd bring you this website, countyhealthcalculator.org. It's sort of cool. It tells you for your state or your county what percentage of people are not in poverty, which they define as, or they have below a certain income level, which they define as greater than 200% of poverty, and what percentage of people have some college, which they use as a marker for education, and they compare it to the best or worst states or counties, depending on what you're doing. And it has a slider that you can move to show that if like 10% more people had some college, what could we expect the impact on morbidity and mortality to be? That's, you just said that. So here's some data, I thought I'd show Oregon, we're in Oregon. Oregon's good, it's near the top. In education, 63% of people are at least at 2 times the poverty rate. I think I inverted this, so 67% of people twice the poverty rate, and 63% have some college. There are over almost 13,000 deaths a year, 200,000 people with diabetes, and almost $1 billion spent on caring for diabetes. And even here, if 5% more people attended some college and 4% more had an income above twice the poverty rate, we could expect to save 1,300 lives, prevent 11,300 cases of diabetes, and eliminate over $50 million in spending a year. That's all by changing the circumstances in which people live, not the medical care that they get. I just thought I'd throw this in. The Clackamas County is the highest in terms of people not being in poverty. Wheeler is the worst. Still not terrible compared to some places in the South. Benton County is the highest in education. Jefferson County is the lowest. And I just throw in some other counties in Oregon. Oregon does well. You're not surprised at that. You're used to doing well because you're in Oregon. I just graphed it here. They're all above 60% in all these major population centers in Oregon. This is a graph. This is Wolf's thought experiment that kind of illustrates what I said. This is in each year how many people would have not died in purple how many people didn't die as a result of all medical advances. And these big, tall, reddish purple ones are what the death rate, the deaths that could have been averted if everybody had the education level. We keep going back and forth between education and income because they're tied together. But if everybody had the education level of the highest educated people, that many deaths would have been done. So we're working down here, and the world is working out here at a much higher rate of death. So what do we do? Well, Bradley and Taylor, actually social scientists also, said, maybe there's a little bit of a mix-up here. People say the U.S. spends so much more on healthcare than other countries, but really other countries, those other developed countries, spend much more on social services. So if you add it up, they come closer. We still spend more, but we're mostly unique in that virtually all of that money on social services and medical care is spent on medical care. And they spend more on things like keeping people housed and fed and educated. So what can we do? Well, the White House studies, I said, demonstrated social class is literally connected to health, but Marmot himself was president of the British Medical Association in 2011 and initiated a study on the social determinants of health to see what communities could do. And they tried to find out these things. What are the principles for addressing the social determinants of health? What is the evidence for what interventions are effective in ameliorating them, both directly and indirectly? And they did a searchable database of best practices. So in this town, they were doing this thing, and it worked really well. So if you want to address this problem in your town, you might want to look at what they're doing there. And it was put together by the Medical Association, which is an answer to a question of what can doctors do. Well, doctors may not be able to, through their practice do it, but they can be important players in the community, in the society. And BMA did this. They had a bunch of policy objectives, which all are reasonable. They're not about creating equality, they're about creating equity and opportunity. I won't read them all, but they're all sort of reasonable things. Another model that was developed in the US, which was popularized by Gawande in his New Yorker article, The Hotspotters, and featured Jeff Brenner in Camden, was Brenner used geomapping to find out where in Camden were the most healthcare costs being generated. And he found that there were actually two spots, an old people's home and a housing project, that were generating most of the costs. And they tried to develop some programs to address that, which included putting a clinic in that project, but also sending people out to people's houses and finding out. So, I think about this in our practice. Here's somebody, he never comes into his appointments. Nobody's ever been to his house. Send somebody out to his house, find out. Good thing he didn't try to come in. His front steps are so rotten, he probably would have fallen and broken his hip if he tried to leave the house. Or, I'll tell you a true story. It actually happened in my practice, my colleague's practice. We had a patient who had congestive heart failure, refractory congestive heart failure, who was a patient of one of my partners, and got admitted to the hospital at least every month. And she always came in with the same thing: decompensating congestive heart failure, and her legs swollen up like this. So we would give her some IV Lasix, a shot or two, and by 24 hours, she had lost at least 20 pounds of fluid. And so we would say, Mrs. Jones, her name wasn't Mrs. Jones, just for the record, are you taking your Lasix at home? And she would say, absolutely. So we couldn't figure it out. How come she, and then she would go home and she'd be back 3 weeks later with her legs swollen up like this. And so finally her doctor, my partner, decided to go out and visit her house. And he knew she had a hospital bed, and he knew she had a hospital bed because he had ordered the hospital bed because she needed it. But what he didn't know until he walked into the house was there was no way that big hospital bed was getting down the hall and around the corner into her bedroom, so she slept on it in the living room. She also had a couple of teenage grandchildren living with her who sometimes had their friends over, and they watched TV in the living room where her bed was. So the last thing that she was going to do was use the bedpan or take Lasix, so she'd have to either run down the hall or be using a bedpan in this room where her grandchildren and their friends were hanging out. So, in fact, she wasn't taking her Lasix. It makes perfect sense when I tell you the story, I think. But I never would have guessed it. And he never would have guessed it and didn't until he actually went out to the house and saw the situation that she lived in. And being a good guy, he also built a curtain rod and a curtain to separate off her part of the living room from the other part of the living room so she could use her bedpan, and she didn't get readmitted for 8 months. So sometimes having people go out to people's houses and find out what the actual problems they're confronting are can begin to address them more than we're capable of doing when they come to the office or to the hospital. Well, I'm just saying there's other organizations that are doing that. In Kansas City, CCO is a faith-based organization that works on trying to find out send people out to people's houses. I mean, another big example is Jeff Brenner, in a talk I heard, talked about medicine reconciliation. Y'all do medicine reconciliation when people come in, you have your EMR. So you have your EMR, and this is the medicines you're supposed to be on, and then the pharmacist asks you what medicines you're taking and matches them up. And Brenner says, how can you know this if you didn't go to their house and go through their medicine cabinet and go through their drawers and find the pill bottles that are half full or half empty, some with the generic name, some with the brand name, some 2 years old, and you don't know what somebody might be taking by that basis. So he thinks, and I agree, that if you don't actually go to somebody's house, your knowledge about their health is going to be very limited, and your ability to intervene is going to be restricted by what you know. You don't have to go, but somebody should go. It could be a community health worker making a lot less money than a nurse, certainly a lot less money than a physician, and maybe even has the advantage of knowing the community or speaking the language or understanding the cultural values. You know more about CCOs than I do. I think you've heard this Kitzhaber quote about how much money it costs to take somebody to the hospital once they're dehydrated and have heat stroke compared to buying an air conditioner. And it's working pretty well. I actually, it's not perfect. There's been some problems, but overall, what I've been able to read about the CCOs is they have functioned a little bit. They've improved the process and coordination of care fairly well. We haven't seen any real ACOs in Kansas City yet, so I'm interested in hearing your appreciation for this. And you know this because you live here. If I was talking to somebody in Kansas, I could tell them about the Oregon CCOs. But you have some local control with community boards that decide how they can spend their money, and so one community might choose to spend it one way, another community might choose to spend it in another way based on the social determinants of health and the medical needs in their communities. That's the reference. It's pretty recent, actually. So in summary, we have, almost summary, social justice and health says we should have an equitable, and I think equitable is an important word, not equal, but equitable distribution of health resources for everybody. We should understand that the impact of the social determinants on health are much greater than anything that we do once the people get sick or once they finally make it into the office. We should recognize that there's systemic injustice and try to advocate for some positive change to address these things in the health system, because doctors have a lot of clout and are often respected in the community. We need to understand context that people live in, and I'll try to eliminate structural violence. Some reasons, you hardly ever see brownfields or former pollutants, lead car factories next to rich neighborhoods. They're always in poor neighborhoods, so people are exposed to that kind of structural violence, as well as the actual violence that may be existing in neighborhoods. And understand how social issues lead to poor health. Health in all policies means we don't think just about what we deliver in the office and in the hospital, but we need to work in the community, look at transportation. Again, I have to compliment Portland. Your public transportation system leaves ours in the dust, but it's a low bar. Ours is just terrible. How we use land, how our built environment is very important everywhere, but it's particularly an issue in rural communities. I don't know rural Oregon, but I know rural Kansas. And typically what you have is a dead downtown, and 3 miles outside of town is the Walmart and the high school, because the land was cheap. And you can't get there if you don't have a car. And people don't walk in their everyday life like they used to from their house to downtown to go shopping or to school. So built environment, we had a very terrible incident about 10, 12 years ago in Kansas where a small town, Greensburg, Kansas, was wiped out by a tornado, virtually. And I drive through it every year. And I've been able to watch the rebuilding of Greensburg, Kansas. The hospital, which for many years was being operated out of an old Quonset hut, they've now got a lovely new hospital. No doctors, but they have a lovely new hospital. They depend on locum tenens physicians. But in the process, they brought a lot of people in who said, let's build the high school downtowns so kids can walk. I mean, we're not talking a town of 1,200 people. It's not like a big distance. So the kids can walk there instead of having to drive to school. Let's put the hospital, the shopping, where people can walk to it and get some exercise in their regular life. Plus, there's issues of exercise. Are there parks? Are there places people can walk? And sidewalks. In my neighborhood, there's a lot of streets without sidewalks or torn up sidewalks, and people, especially if they're older, and we say you should go walk, are at risk not only from violence, but from falling down because there's no, or getting hit by a car when there isn't a sidewalk. So sidewalks become important. One woman told me when I told her that she should get some more exercise, she could just walk. She didn't have to, join a gym. She said, "But how can I walk? Because I don't have a car." Took me a little while, but it's another thing that shows you if you don't ask, you don't find out. So in her neighborhood, there were no sidewalks, so the ones that were there were broken up, and it was hard to walk on. If you walked in the street, you could get hit by a car. And so all of her friends who walked either drove to the park or drove to a mall where they could walk around. She didn't have a car, so how is she going to be able to walk? That's built environment. And environmental justice understands things like brownfields and old battery factories and things that cause toxic environments for people. So in summary, social conditions are the biggest determinants of health status. Social inequities, or lack of social justice, results in health disparities. Addressing inequities decreases disparities and the burden of ill health. And physicians can and should be involved in efforts to address disparities and advocate for social justice in order to improve the health of their patients and communities. So I end with a couple of quotes. This is from Martin Luther King, who said articulately, "Philanthropy is commendable, but it must not cause the philanthropist to overlook the circumstances of economic injustice which make philanthropy necessary." Well said. Long sentence. The author, Jonathan Kozol, I thought put it a little bit more pithily. Charity is a good substitute for justice. Martin Luther King, quote to end, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." And I would postulate that as physicians, it's part of our role to find ways to address that. So thank you very much. And if you have comments, I might even take questions, although I don't guarantee I know the answers.
Coming from a state in which Mr. Brownback is your governor, I can't help but think that really what you're talking about is immensely contributed to by the political climate, not only in your state, but in the United States. And it's hard for me to feel other than what you've talked about is a central point in the election that we are all confronting in its various peculiar representatives. I think Mr. Brownback is quite far to the right.
Yeah, although he's got a lot of friends. I'm not sure that's a question. I agree with you. I can tell you horror stories. I mean, sort of a little bit, maybe in Oregon, you're closer to those other European developed countries than we are in Kansas and Missouri. This latest budget round, the budget for the state is $54 million short. It just had a $17 million, which translated into percent is a 3% cut for the year, which is 12% for the rest of the year, for the state universities. We didn't expand Medicaid, so to the extent that Obamacare has been beneficial in insuring more people, no more people are insured in Kansas than they were before. So those things are true. I didn't put these on my slideshow, but I can show you. I did go to the Democratic caucuses in my we have a caucus state, and you may have heard that Sanders won the Democratic caucus by 2-1, and a lot of that was I went to a caucus, and in my particular venue, there was more than 3-1, despite all the elected politicians in the Democratic Party supporting Clinton. And no small part of that was driven by people's concerns about their health and their health care, and that Sanders, whether it would be implementable or not, each candidate had somebody who spoke for them, and the person who spoke for Sanders started, I mean, he wasn't the best speaker, but he's talked about how, he's a young guy, he said, I have a 4-year-old and a 2-year-old, and when my 4-year-old was a year and a half, she was diagnosed with AML, and she almost died, in part because we were terrified about bringing her to the doctor when she was sick. We didn't think she had cancer, but we knew she was sick, but we were worried about a really big bill, and she was pretty far gone by the time we brought her in, and luckily, he thinks, I'm not going to exert, that she's going to get better. Because after a long period of time, she was able to get Medicaid and be covered. And it was a passionate, if personal, talk, and that room was full of people who resonated with that they didn't have health care, or somebody in their family didn't have health care access, or didn't have insurance, or they knew that they were. One way of measuring vulnerability is how many paychecks are you from being homeless? Doctors tend to be more privileged in that way, but for the average American, if you stop getting paid for 3 months, maybe 6 months if you had a good job and a lot of savings, how long will you be on the street? Will it be before you're on the street? Well, or living with a relative if they still have a house. So people are very worried. And some of that shows up as Donald Trump in my state. He didn't win, actually. Cruz won, which I'm not sure is big. But, you know, it's obviously related. It's related to intent. And you can't do a good thing if you're not even trying to do a good thing. I'm sorry, go ahead.
I didn't see income disparity per se on your list, but it is on the WHO list of determinants. Can you tease that apart from poverty? And we hear a lot about income disparity in our country now.
You can. I had a limited number of slides that I was going to put up, but I don't swear that I'll get all the numbers right. But there was another study that came out not long ago that looked at the U.S., Britain, and Europe, sort of grouped together, in terms of the incidence of common things like heart disease, stroke, and cancer. And it was higher in the U.S., but the relative risk but the other thing that they did was they looked at income, they only used tertiles, so top third, middle third, and lower third, and so they looked at the risk of developing these diseases if you were in the bottom tertile compared to the top tertile, and the disparities were much greater in the U.S. and in Britain, actually, than in Europe for some diseases. And for some diseases, they were lower in Britain as well. But even when the difference was 2 to 1, say, for stroke in Britain as well as the U.S., you had to put that in the context of the risk of stroke was only 2/3 for everybody in Britain than it was in the U.S. So yes, a lot of our income disparity impacts on that, and it impacts on it both because of the disparity itself, but also because as this disparity grows as a result of money being transferred to the top, there's not only less money for people at the bottom, but as in the slide of they become desperate. Their hope becomes less. So in a sick metaphor to Kansas, yeah, they just cut our budget a lot because there's a $54 million deficit, but it's not going to likely get better next month when the budget estimates come in. And we could cut, I was going to hire you in April on the faculty, but we're going to put it off till July because we want to save 3 months of salary. That was money that was budgeted, but you know what? Probably we won't have the money in July, next fiscal year. And so when you start to realize that, it's one thing for me to put together a budget in the medical school, but if you're a person without a job who's been unemployed for a long time, is getting to middle age, has little or no hope of getting a job or being able to get a house again, and is in chronic pain because of the job that you did do tore apart your body, things like death from opioid overdose or from suicide become more and more common. And I would throw in a pitch here. In my state, they passed a law that says anybody can carry a concealed carry a gun without a permit or a license or any training. They exempted healthcare facilities and universities until July 2017. And there's no evidence that the legislature has any intention of expanding or continuing that exemption. So everybody's panicking about what it's going to mean to a professor to take a student into their office and close the door and tell them you're failing. People get paranoid about their own safety. Or some nut pulls a gun in the waiting room of my clinic. And then to make it worse, 3 John Waynes pull their guns. And now the police come and they don't know who the original person was and who's going to get caught in the crossfire. So we worry about that kind of stuff. Although from a population health, social point of view, what it means is more people will kill themselves. Because often, not always, but often suicide is impulsive. And people who attempt it don't always attempt it again. But if they took pills, they got about a 95% chance of not attempting it again and making that decision. And if they used a gun, they've got less than a 5% chance of being able to make that decision the next time. And that's 60% of gun deaths. And the data is pretty convincing that the less restrictive your gun laws are, the more people, especially young men, kill themselves. And do I believe that people are more depressed? Adolescents are between 16 and 24 are more depressed in Montana than they are in Massachusetts? I have no idea. But 10 times as many successfully kill themselves in Montana as in Massachusetts. And that's across the board. If you take the 10 states with the tightest gun control laws compared to the 10 states with the loosest, the adolescent suicide rate is 10 times higher. So I don't know how I digressed on that, but disparities are a big deal. Does that help at all? Yeah, the income disparity makes a big difference.
Yeah, I asked about income disparity. You're responding by talking about despair.
Well, despair is sometimes a result of income disparity. Yes, sir.
There are a lot of older people sitting in this room.
Really? They look like normal to me.
my co-geriatric group, my co-presbyteers, I don't know what you call them. But we look back, we were teenagers in very heady times when this country was filled with social promise. We saw desegregation starting slowly. All these things, and now we look back and we see what this country's become. Anyway, you're younger than us.
I don't think so much.
What would you do?
Well, I'm not really a young person. I will say I have a Medicare card in my pocket. But I think that we need to continue to struggle. We need to, I'm a member of PNHP, which was, PNHP Oregon, which advocates for a single payer health system, was originally who brought me to Oregon. And I think that having some sort of national health system that covers everybody, I happen to be in favor, as is PNHP, of a single payer system, is a necessary component of creating health equity. It's not sufficient because it doesn't address the social determinants of health. But it does mean that even beyond Obamacare, with Medicaid expansion in Oregon and not in Kansas, we address the fact that there's 11 million undocumented people who we can say, well, they're off the table because nobody can say we want to insure undocumented people, but they're still there and they still show up in your emergency room. And so that becomes, you have to have a starting place where everybody is in the same health system. And it's worked pretty well for those socialist entities like the Army and the VA and Medicare. Now, and I hasten to add here, I know Medicare doesn't pay very well, but that's just a matter of how much is invested in it, right? The distribution of services across Medicare is equitable for everybody who's over 65 or disabled. Maybe, and if we just said, you know what, everybody's in Medicare. It's the old people who cost a lot of money anyway, so we're not going to increase the cost a whole lot by putting everybody in it. Certainly not in proportion to the number of more people who get put in it. And now, guess what? It'll pay enough because we'll all be in the same system. We'll have the same insurance. So I think that's an important first step that physicians are relevantly arguing for. And the other part is the well-being of our patients, which is the sort of medical term for people, we have a medical vocabulary. And for our patients, we need to say, when they show up in extremis, there's only so much I can do. But they didn't have to be this way. We need to say that they shouldn't, if a person is homeless, Colorado, Houston, New Orleans are working on homelessness. They bought into this principle of housing first, which is, if you don't have a place to live, how can you really successfully get a job? How can you kick drugs or stop drinking if you're living on a heating vent? So they have, nobody can eliminate homelessness completely, because sometimes somebody who wasn't homeless yesterday is homeless today, but they virtually eliminated homelessness there. They said, rather than say, you have to clean up your act and stop drinking before we'll work on getting you a house or stop using drugs, they said, first we'll get you a house, and then we're going to expect you to do it. And the results are phenomenal, because you have to start with first things first. And so I think we need to be able to advocate for that stuff. We are relatively powerful, relatively privileged people, and we have insight into what causes disease.
A lot of the stuff we're talking about is on a grand scale. What do you think is the best way for the individual to have the biggest impact affecting their patient population?
Well, I would say, I'd leave it to people who know the environment, but banding together with others. The AMA, another socialist organization, calls in its Declaration of Medicine's Contract with Humanity for physicians to advocate, not just for their patients, like, hey, I know this person is uninsured, but they really need this surgery or this scan, but to advocate to ameliorate the conditions in which people live that create evil disease. So we could work through the AMA, or through your specialty societies, or through PNHP, or through community organizations of which you might be a part. Maybe some of you are members of churches or other community organizations that could be trying to help support initiatives like hotspotters and have people go to people's houses. You can work on saying, and Portland is very good on this, but we need to, when we're going to rebuild stuff, we need to keep in mind its impact on people's health and access to healthful behaviors. And you could vote. I guess you probably do that. I'll tell you the cool thing about a caucus, it's like 3.5 hours. You go to vote in a primary, you pull a lever, you're out of there. In my neighborhood, hardly anybody votes, so it's like a 5-minute wait. We don't pull levers, we have computerized stuff. But what's cool about it is you actually get to see the other people. You don't just go mark your ballot and then tomorrow you find out who won. You get to see who's there and who's coming out and and you get to talk to them because you're in small groups as you talk, and you find out what they're concerned about and what their issues are. So involvement in your community is probably the most effective way. Oregon, and I'm going to take a risk here, but I'm among doctors, so I hope it's not too big a risk. We still don't have fluoridated water here. Now, I lived in San Antonio when they finally got fluoridated water, and it was a big victory. It had failed 3 times before they passed it. At the time that they passed it, the mayor led the charge to fluoridate the water. The entire city council and the county board was on board. Most of the businesses in town were on board. The medical school and the dental school for sure was on board. And a massive advertising campaign went out, and it passed by about 52%, with a completely unfunded other side. So there are still things that you can achieve. Now, maybe you don't believe that. Maybe you believe fluoride is poison. If so, you're wrong. But I had the privilege of working in San Antonio, where I got to see, when I moved there, 5-year-olds with sets of stainless steel teeth. So on the medical side of things, it was a great testimony to the skill of our pediatric dentists, that these little children who had lost all their teeth could have rebuilt stainless steel teeth so that they could eat and get nutrition. But there was another side, which is, why did they lose all their teeth and have to have them rebuilt? I pick on that because, how can you pick on Oregon? It's hard to find things that you do too well. But working in communities, not just in your professional organizations, is probably the most effective way to do it.
I think we're at our time. Weighty topics to solve today.
Thank you.